Good evening, everyone. Welcome to Rehabilitation Sciences YouTube channel. Today we are here with a very interesting topic, neural rehabilitation. And we have with us Dr. Suhana. Welcome, Dr. Suhana, on YouTube channel of Rehabilitation Sciences Group. And before we make your lecture start, we would like to have your consent for making your lecture live on YouTube, ma'am.
Sure, thank you. I agree with that. Thank you very
Thank you,
much
Dr.
for asking.
Suhana, for giving consent. And moderator today, Dr. Sagun Agrawal. He'll formally introduce our faculty today and start the session. Dr. Sagun, you may start the session, sir.
Good evening, everybody. Welcome to the Rehabilitation Science Group for today's lecture of neural rehabilitation, reflex modulation in the interlimb coordination. We are having with us Suhana Jamil Ahamed. She did her bachelor's in physiotherapy from India and then master's in the kinesiology from the University of Texas, Austin. And she has latestly she has presented her paper, and from there she got the People's Choice Award. We welcome you, Suhana, on the Rehabilitation Science Group. You can start your lecture.
Thank you very much for introducing me. And yes, so my name is Suhana Ahmed. You know all of that by now. But then I want to say that I'm still a graduate student. I was actually planning to graduate in fall 2020, but then COVID-19 happened. It all, and everything was put on hold, including my research study and my plan to graduate. So my research study was all about reflex modulation, and this is what I'm going to talk about, that how reflex modulation is the part of underlying mechanism in interlimb coordination and how this underlying mechanism can be used in neural rehabilitation further. So, and we already know about statistically about how neurological disorders place a heavy demand in the persistent efforts in the field of rehabilitation. If we look at the data collected by GBD, it is one of the leading cause of death, causing 9.1 million deaths in USA and 16.5% of global deaths around the world. And also, additionally, this is one of the leading cause of disability, causing 276 million disability adjusted life years by age and sex in 195 countries and 11.6% of global DLY. So it's we say that it goes without saying that we need to work in this field and we need persistent efforts to go forward. Disability in general is basically the outcome of reduced leg muscle activities and also the compensatory changes which occurs due to the altered spatiotemporal characteristics during walking in general. So basically, studies have shown that we are not able to resume the walking necessary enough to perform daily life activities, and that goes without saying that's a very higher risk factor to work on. So with time we are able to develop lots of neural rehabilitation approaches and techniques, but the thing is that there's a catch in that. Even though we have very popular techniques and we are widely using them, they are preferred geographically different in different way, but then we do not have evidence enough, especially the randomized controlled trial studies, uh, validating the efficacy of these studies. Pomeroy et al. Actually recommends some of the studies which have had whose efficacy has been proven by randomized controlled trials, but we still need to work on them and about improvising them, and how we will see that somewhere the reason that all these studies have limited results because we do not know the underlying mechanism completely. What happens to the sensory motor system once spinal cord injury or stroke or any neurological disorders affects that. So usually what happens in that affection, and how uh, how does it get affected, and how it goes from like normal motor mechanism to the abnormal motor mechanism. That's what we are going to explore today. So I just want to give you a reality check about these studies, about the evidences. I have included this one of the meta-analysis study, which was done by Pollock in 2014, and he included more than 121 interventions, and he compared them. Some of the interventions were used individually, some of them were combined, but the result of all those comparing these study was that, definitely these studies play important role, these rehabilitation play important role in rehabilitation, but we do, and but no one precedes over another. They all are equal, they all are effective in some or the other way, but they also have limitations. I'm going to show you one more study which was the part of previous meta-analysis. This study was done by Jorgensen in 1995, and it shows that, by the way, these people use Babat's technique, that at the beginning of rehabilitation, 12% could walk with assistance, 37% had independent walking function, but by the end of rehabilitation, 11% could walk with studies and 50% had independent walking function. And this rehabilitation was continued for 12 weeks. They kept on exploring the rehabilitation part and how the improvisation or the rehabilitation process is going after 6 months and 12 and 1 year also. So they realized, they also concluded one of the very popular notion about the neural rehabilitation, that effective rehabilitation is during the first few weeks or first 12 weeks or first 6 months of the first 12 weeks post stroke. So you can see about this that, I'm mostly talking about stroke. So the thing is, most of the studies are performed in post stroke patients. The reason goes without saying that it's one of the most widely basically widely popular, no, I won't say popular, but then that would be a wrong word to say, but then that's the one which affects mostly among the all the neurological disorders. So stroke rehabilitation might serve as a dominant model for all the other neurological disorders, and we can definitely modify them whenever we need to, whenever appropriate. And then this is a generalized sensory motor system, which I'm trying to include here. What happens in a normal mechanism? So we have, of course, the cortical region control, our visual system, our progress system, and they all combined together and integrate at the vestibular nucleus. And then further, all those motor commands go all the way to spinal interneurons, and spinal motor neurons or movement is the outcome of this entire integration. We all have extensive studies over the cortical region and visual system integration and proprioceptive system integration and vestibular system or integration already. And this is a widely accepted notion, even in invertebrates, mammals, and humans, how they affect. We have extensive studies available, and we know that they definitely play important role in it. But what happens in the spinal interneuron is in the question. So this is what we are going to understand a little more today. And after that, we will try to establish a framework where we will try to utilize the mechanism happening at the spinal level for better rehabilitation or for effective rehabilitation. So to understand underlying mechanism, I'm going to use information processing model, which basically has three main stages, which has basically stimulation identification. Basically, when you receive a stimulus, to identify that and to acknowledge that. So we know that we receive stimulus through vision, through audition, through proprioceptions, and that includes vestibular system, muscle receptors, joint receptors, and also cutaneous. And we are going to talk a little more about cutaneous afterwards and how it's a novel concept and how we are still trying to develop more understanding towards it. And then comes response selection. So we know that central nervous system integrates, basically accepts this information and reorganizing all this information, integrated, and then there is an outcome as a response selection. So basically this all is happening at the spinal cord. We have already talked about brain earlier. In the spinal cord, we have sensory tracts and motor tracts, which are connecting link between brain and spinal cord. And then in gray matter, we have simple arc pathways, which we already know, or we have a little bit already idea about that what they are. And there is basically monosynaptic reflex pathways are excitatory responses, IV reflex pathways are mainly inhibitory inhibitory responses, and then we have flexor withdrawal reflex pathways, which are actually polysynaptic pathways. And some of the interneurons of these polysynaptic pathways combining with motor neuron pathways of these two reflexes are basically part of central pattern generator units. We will soon discover what central pattern generators are, what are their role in the walking. So to explain that, I am just giving you these two pictures just to give an idea about how they connect with monosynaptic and disynaptic. You can see this classical example of knee-jerk reflex. In knee-jerk reflex, we have one connection, just this one. This is your positive connection or monosynaptic connection, and then we have another, basically two synapses being made, and it is producing an inhibitory reflex. So there it is. We are combining them together, and they work for like contralateral to one another. So you can see that monosynaptic reflex actually also makes synergistic motor neuron with other or antagonist muscle as well. On the other hand, this is a polysynaptic reflex pathways, which is also having some interneuronal connection, and we can see that this is in the deeper part of gray matter of spinal cord. So let's say if you have extremely extreme stimulus, so you hit something in your foot, or you place your foot on something irritant, then what happens? This entire stimulus information goes all the way in gray matter, and then making the disynaptic, basically making all the polysynaptic reflexes here. However, studies have shown that they also make interaction or integration with monosynaptic and disynaptic reflex as well. We will explore it soon about that. So these interneuronal basically combined with the internal circuitry present here, which we are terming as central pattern generators, are the one which are playing important roles, and they have been extensively studied in mammals, specifically cat, and we will talk about that soon. So we know this is the entire circuitry, and I'm going to explain a little bit more about this. That let's say this is a three-layer model basically proposed by Kai Lee, and in the it's a modeling study, so we still need to explore how it works and how it exists in humans. It was all about computerized model. He has also proposed 4-layer model, 2-layer model also. So we need to explore that further in humans yet. In this, you can see that there is a rhythmic generator, basically interneuronal circuitry present within gray matter towards the deeper end. And then we have this connection made with motor neurons when stimulators, monosynaptic reflexes, disynaptic reflexes have been produced. So they are also the part of internal circuitry. And this entire portion together is termed as central pattern generators. So few of the internal neurons work as rhythmic generators, and few of them work as pattern generators. And then we have some evidences about the existence of CPGs from animals, and basically how this concept of CPGs came in the picture. So first, it was observed by Florence and Frisberg in a paraplegic dog with transected spinal cord. They saw that even if complete transection, here the dog was able to perform rudimentary stepping. So that's which was really just observed. And then finally, Philipson also in 1905 explored it more when he also observed the same thing. And he said that, okay, these are part of central and reflex mechanism. And then came Sherrington in 1910, and he did a very extensive study over these basically rudimentary steppings, and he termed these stepping movements as fictive locomotion, and also understood that these are the part of proprioceptors. Basically, what happens here that then then Cosqua did the cellular evidence, and actually he was able to locate the locate the central pattern generators in lamina 7, and by using FRA stimulation neonatal rats. So basically he said that flexor reflexant afferents, which are basically your polysynaptic reflexes, combines with monosynaptic reflexes and generate and gives you the locomotor pattern, and which we have already seen through the modeling also. So they both are saying the same thing, and that also says that we can definitely utilize those modeling studies for further understanding these underlying mechanisms. And when it comes to the organization of these central pattern generations, how they work, Brown has proposed half-cinder model, which is widely accepted model so far. Burst generator model is equally popular too, but these are the models which are yet to be explored more, and which needs to be further studied. And then there are some more evidence that about this question, that if we know that if we are capable to move or perform movements without the control of supraspinal activation or cortical region, then does that mean that cortical region has no role in it? It definitely has a role, which was explored by basically uh, having a transaction level in the cats at different level. And basically when they varied, they identified that brainstem is the cortical region, is the part of cortical region which plays important role in regulation of those movements. What happened in the cats, that they were not able to initiate the movement. They already were performing the existing movement, but they were not able to initiate it. And it was further confirmed by depositing the noradrenergic agonist, which are basically those substances which mimic the activity of supraspinal activation. So the deposition of those substances also elicited movements in the cats, especially. So this validated that yes, supraspinal activation has definitely important role about it. Now, when it comes to another influence of somato-sensory, if we know that cortical region also has influence on the movement, spinal cord circuitry also has effect on the movement, then what happens to the edge reflex or to the cutaneous reflexes, or the basically sensory afferents coming from the outside or from the peripheries? So what happens, they saw that if there was when they tried to lie down the cats or dogs in their study, there was weaker generation of rhythm during stepping in air than relatively when they were standing, and they were just crawling and they were stumbling during stepping, rudimentary stepping. So that produced that definitely the stimulus from the periphery or from the atmosphere also plays important role in this. To explain that, they further basically focused on the load receptors in foot and hip joint position and cutaneous afferents. My current advisor, Dr. Abraham, also has explored all these receptors and this mechanism. And there has already been so many studies done. The conclusion of Dr. Abraham was that our current understanding of the existence of central pattern generators and influence of somatosensory feedback from the periphery is valid, and it's basic. He had all the conclusions similar to the previous studies done. Now, when it comes to human, what about the human? What about existence of CPGs in human? We will talk about that further. But before that, let us summarize what we have understood so far. So we have control from brain, control from CPGs, and control from or influence from periphery system, which I'm trying to show you here. You can see that it is a closed loop. Let's say there's a displacement of limb right here. This sensory information as a monosynaptic, disynaptic, and polysynaptic pathways goes to that lower limb as well. And that lower limb also sends some information right here through force if there is a force generation. And this entire information also goes to this within spinal cord, and also goes to brain or midbrain through spinal cord, of course, but then you can say it's the white matter which is involved. What happened in this, that once this information is gone, or let's say cat decided to move on its own, the brain commands to the midbrain that how to perform a movement. We decide the velocity, we integrate it with all the muscles, flexors and extensor muscles, and then we perform these movements with the help of then we are also deciding the amplitude of muscles. So all this information is integrated, and then we have an outcome as movement. So far this has been valid, this has been extensively studied. Let's see what happens in human. So in humans, we actually failed to see existence of CPGs in most of the initial part, except for the studies which were done on the spinal cord injury patients, or in different ways, and especially in the complete cervical level spinal cord injury patients. But other than that, we are still trying to explore that. However, we have found phylogenetic evidences from monkeys, from primates, but that's also in question because so many studies have shown that we have failed to see the existence of CPGs in primates. Basically, what happens in these spinal cord injury patients in humans, we are not able to completely decerebrate, and we are not able to see that situation. So it's really difficult to further study it further. However, in the complete spinal cord injury patient, by using epidural electrical stimulation, we are able to see that we can see some rudimentary stepping in humans as well. But we definitely have influence of somato-sensory feedback from periphery in humans. We will talk about it, how we study it, and I'm also doing the same study in humans. So we will talk about it in detail. But before that, I want to address one thing, that we definitely have this accepted notion that cortical region plays important role in vertebrates, invertebrates, and humans. So we know that cortical region is playing, and we also have some studies available which are saying the existence, which are reclaiming the existence of CPGs, but we still need to explore that part. About the cutaneous studies or influence of somatosensory feedback in humans, there are a few approaches which I have mentioned here. Basically, understanding the mechanism of monosynaptic reflex pathway. We call them as H reflex, which are coming from the reflex function, and we study them further. And then similarly, we also study stretch reflexes, and we actually use the modulation curve of rectified EMGs and everything. And then we also have average surface EMG myogram, which I'm using in my study. So I'm replicating a study performed by my advisor in cats, and I'm doing it in human. Basically, I'm trying to utilize those cutaneous receptors, nociceptors to be very specific, and I'm utilizing them in the upper extremity and basically seeing the muscle activation in the lower extremity to see that connection between those two limbs and how these reflex modulation occurs. And also there's another way to study these reflex modulation, and that post-stimulus histogram is basically utilizing or understanding or analyzing the motor unit firing rates. So we know we have different methods, and cutaneous reflexes specifically have been studied and have been validated by Dr. Zair in his study, and he has done the study in sitting, but he has done his studies further in walking, in cycling, and further studies also. So I was inspired by his studies, and I took this idea of comparing my results in the sitting position with walking. So I'm actually validating the existence of these reflex modulation and also comparing them in different positions. We will see why. Because in different studies, especially in studies done by Dyson, Dr. Zair, they always claim, and they have shown in most of their studies that these reflex modulations are task dependent. In different position, in different dynamic movement, they have different result or different output. You can see that modulation of tonic motor output and its reflexes was shown, and it was in walking. Whereas the modulation of tonic motor output by cutaneous nerve stimulation, they both were observed in walking differently than what they were observed in cycling. At the same way, there is phase dependent of reflex during rhythmic motion. That, let's say if we are taking example of walking, so basically we have different reflex modulation when we are transitioning from swing phase to stance phase, and from stance phase to swing phase. We will explore it further and we'll talk about it later in our previous study. So far, we have established in human that we have cortical region influence. We have somehow doubt questionable, but some people are supporting it and some people have shown it. Some scientists have shown it. So we have influence of CPGs, and then we also have influence of reflex modulation. So we still need to focus it, and we have talked about it, how what happens in human, again, the same thing as the cortical region. And then we have CPGs and oscillatory working together, units working together within spinal cord, and they provide a motor neuron affection when they receive a stimulus, sensory stimulus, all the way through spinal cord. Let's talk about this information processing model in humans in detail, because we need to understand how the pattern is developed and how pattern is generated. Remember, I talked about Brown's study that he has proposed a half center model. This is how exactly it looks like. Not exactly, but Rosignol has really concluded all the studies done from the mammals and from the humans both, that how this model is being so widely accepted. And so in this model, you can see that the stimuli or sensory information is coming from the skin. It's going all the way in the spinal cord. And then from spinal cord, we have a lot of integration. We also have this information, sensory information um, being passed to the cortical region. And then we have motor influence from the cortical region, which is further integrated with central pattern generators or interneurons in spinal cord. And we have most the agonist muscles and antagonist muscles accordingly, either being facilitated or inhibited. So basically we have flexes being excited, or we have extensors as inhibit in this picture. So this is, we have understood so far that if we are working, if one leg is in flexion position, the other leg is in extension position, and makes sense, right? That's what we see so far. If one muscle, agonist muscle is in flexion, the other muscle is performing, is opposing that movement. So let's conclude what happens in the walking so far, what we have studied so far. We understood that there is a transition, there's a different reflex modulation in all these transitioning period of the step cycle. What in general, what happens that cutaneous reflex, when we are in swing position, they try to correct our stumbleness. If we are on one foot, we might stumble. So they're trying to correct that stumble. And at the same time, the receptors from the muscles, they are trying to stabilize the trajectory on the other foot. So we definitely have, there is interlimb, connection and the regulation being played in the picture. At the same time, when we are transitioning from swing phase to stance phase, we have cutaneous reflexes, which are basically, and muscle reflexes playing together to placing the reaction, or basically when we are trying to place our foot on the ground. So they need to integrate together, and definitely there has been observed the CPG existence and in different studies within this period. And at the same time, when we are moving again back to stance, in the stance, we have weight support and stability and cycling timing being performed by the muscular receptors or muscular modulation. And from the cutaneous reflexes, we are trying to understand, or we are trying to develop a stability when we are moving. And then at last, we have stance to swing phases. And then they are the muscular reflex, edge reflex modulation is performing unloading, and cutaneous reflex modulation is performing the withdrawal of from previous stage. So you can see this loop going on, and we can definitely see the connection, how it plays in the picture. So we have understood that what occurs, what happens in the normal underlying mechanism. Now, what happens when in the individuals with neurological disorders? Let's talk about that a bit. The reflex modulation during walking were obviously not able to see, because patients were not able to perform movement. But when we provided them some stimulus, we were able to see excitatory modulation of edge reflex and cutaneous reflex both. And Dr. Zaire also studied in the stroke patient that with the mice stroke patients with mild spasticity, showed the cutaneous reflexes and its reflexes both post peroneal nerve stimulation during treadmill. So we definitely know that this internal circuitry is maintained or well preserved even after stroke issue or any other spinal cord injury issue, and we can definitely utilize this intact interneuronal structure for further rehabilitation process. So when we talk about the rehabilitation process and utilization of these interneurons in rehabilitation, Arya and Pandians have proposed and have also seen that those previous rehabilitation techniques are already using these neurophysiological approaches, underlying mechanism, but at the same time there is not completely understanding of how we are implying it and how it changes the underlying sensory mechanism and motor mechanism. At the same time, he has also observed some of the recently developed studies like virtual rehabilitation and some studies like body weight support um, body weight support treadmill training. These kind of rehabilitations are already using these internal limb neural compilation. Just to explain or just to discuss a bit, I have explained it here that we know that there is a coordination between upper extremity, there's a coordination between lower extremity. We still need to explore more between the coordination or the connection between the upper extremity coordination and the lower extremity coordination. And I'm myself is trying to do that. And at the same time, so far, whatever we have known, we have whatever from the mammals and humans, Rosignol has really explained everything in his studies, and he said that how we can imply in the complete spinal cord injury patients. Basically, he's using the same stimulation idea and how we can further modify the pre-existing techniques like Roots approach and any other or Boba's technique. So we know that we already have effective rehabilitation techniques. We just need to further modify them, further improvise them. So for that, we all need to come together. This is my take-home message for today, that we all need to come together, encourage evidence-based practice and multidisciplinary approach, because modeling and other studies, they also help us understand these different this complex mechanism, and also they are also helping us developing better orthotics, better more robotic devices, and robotic therapies is the upcoming intervention and is already been started in some of the geographical locations already and has been showing effective results. So we need to collaborate together and work on it. This was my time. Let me know if you have any questions and concerns, and if you want to collaborate with me for some studies, please email me on suhana@utexas.edu. Thank you very much.
Thank you, Suhana. It was a wonderful presentation, and I think your takeaway messages might be very well accepted and used in rehabilitation all over. Suhana, although most of the studies that you mentioned as a part of your literature background were on animals like monkeys, cats, dogs, and rats. So these are quadrupedal animals. Like how do you relate these studies to bipedal humans, and what difficulties do you face when you apply research on lower animals and apply it to bipedal humans?
Quadrupedal locomotion has been well studied in almost all the invertebrates and vertebrates. When it comes to close primates or mammals, which are phylogenetically close to humans, we have failed to see all these things. So, and some of the very few studies have shown them. So we are still exploring that part. But when it comes to seeing these in human, this reflex modulation and existence of CPGs, we are saying and we are accepting the notion that bipedal locomotion is conserved from the quadrupedal locomotion. So because we were somewhere, sometimes, we have been evolved. We have evolved with time from quadruped to biped, and we all have seen it in the motor development in early childhood. And we have studied those reflexes developing over the motor development happening in the child. We can see that we are having that conservation of quadruped locomotion.
Right. Thank you. And yeah, what is your opinion about spinal cord stimulation or brain stimulation in eliciting such reflexes?
Lots of studies have shown effective results of those studies, and I'm trying to be the part of those studies as well. Currently, I'm in talk with some of the professors. So far, they have shown effective results, and we know that the way we have crosstalk at the spinal cord level, we have already proved it, that there is crosstalk between the hemispheres also. So we can definitely take advantage of that.
Right. And finally, since you might inspire a lot of young generation students and professionals, any message on how to go about researching this topic further in places where technology is not that great?
I would say, so I am very inspired from my advisor. And when I look at his previous studies, when he has done on 1985, and I was actually also worked recently with one of his student, Dr. Gobert. He told me that there was no technology when he started working there. There was no three-dimensional technique. So we will come up with alternative idea. The key is to be creative and to find alternative solution always. And I'm pretty sure that we might not have very advanced technology, but we definitely can come up with new alternative techniques or new alternative ideas with what we already have available.
Right. Thank you so much, Suhana, for being with us today and sharing your research experience. Thank you.
Sure. Thank you very much.